Okay, I think we are ready to go ahead and get started. My name is Caitlin. I work for the marketing communications team with Iowa Healthcare. I'm gonna go ahead and share my screen. So again, thank you for joining us to get the facts about Peyronie's disease. You'll hear from our expert, Dr. Amy Pearlman, shortly. And prior to that, I just have a couple of housekeeping items to address. So this program is run in a webinar format, meaning that only the speakers will be shown on the screen, and you can use the view controls in the upper right-hand corner of your screen to change your view of the speaker in the presentation. And then you can also use the Q&A button at the bottom of your screen to submit a question during any time during the program. And then we'll also be addressing questions that were pre-submitted during the registration process throughout the program. And then when entering your question, you can choose to submit your question anonymously as well. If you need closed captioning, please turn it on at the bottom of your screen by using the closed captioning button. And then you'll also be able to adjust the size of your captions with this button. So our presenter for this evening is Dr. Amy Perlman. She is the director of the University of Iowa Men's Health Program. So go ahead and take it away.
Awesome. Thank you so much. All right. Good evening, party people. My name is Amy Pearlman. I'm a urologist and I specialize in men's health at the University of Iowa, where I direct our men's health program. I've been here for almost 4 years. Peyronie's disease is something that a lot of people never get taught about when they're growing up, when they're in training, in life, period. It is something that I see most days of the week, several times a day. And I'm here to tell you, you are not alone. I have Dennis Wallace with me. Dennis is a patient of mine. He's a patient advocate. He's a rock star, and he is a celebrity. I'll pull up here. He's actually being featured in this Health Monitor article that talks about Peyronie's, other common men's health concerns like low testosterone, erectile dysfunction, and everything associated with Peyronie's. It's a beautiful article. We're going to try to get it sent out to everyone as a PDF afterwards to take a look. So Dennis, why don't you say hello to the group?
Good evening, everybody, and thanks for coming. I hope that the information that Dr. Amy has tonight to provide to you, that it's going to answer a lot of your questions and maybe allay some of your fears and concerns on Peyronie's disease. And hopefully me throwing in my 2 cents will also help with that.
And Dennis and I, actually, Peyronie's disease is what introduced Dennis and I a couple years ago. So I guess for that, I'm grateful. And it's what brought you into the office. And then it sort of unraveled about 10 other male-specific health concerns that since we've tackled. So Dennis, tell us a little bit about your journey to finding someone to give you that whole comprehensive conversation when it came to Peyronie's, and maybe even a little bit further back from that. When did it start, and what were your first thoughts when you were like, what's going on down there?
Well, I think a lot of this started, approximately about 12 to 15 years ago, when the erectile dysfunction actually came about, and I was diagnosed with hypogonadism. Which is also one of the reasons why I've got low testosterone. The erectile dysfunction was an on again, off again type of thing, and I spoke to my primary care physician about it. And at that time, any of the medications that were available were quite expensive. And my doctor, when he'd have free samples, he'd hand me a couple of them at the end of the visit and that. But it got to the point where I was making up excuses to go see him just so that I could have some. In the last few years, the price of them has come down considerably. And it's been great for guys like me and other guys that are on here or been on these webinars. But approximately about, I don't know, the end of 2017, beginning of 2018, I started to notice the beginning of a curve in my penis when it was erect, coming straight up from, about an inch or two from the base of the head. I'd asked my wife, I said, do you think that's kind of weird? And that she goes, no, you're crazy. There's nothing going on there. Well, that was just the beginning of it. And by the time I was able to get to see you, we had measured it at a 45-degree angle coming straight up. I saw 2 other urologists prior to getting referred down to you. I went through the vitamin E and I know I'm going to screw the name of this drug up.
Pentoxifylline.
Yeah. I've got another name for it, but I won't pronounce it. And it really did nothing for me. The doctor had diagnosed me with the Peyronie's, and it was actually his physician's assistant that got me the referral down to IRL down in Iowa City. And since then, you know, Doc, we've been through a lot together, and we continue to write new chapters to this little journey in that. You've helped me with the Peyronie's. After what we do, 3 sessions of injections, Xiaflex injections. We took that curve from 45 degrees down to approximately 22, 23 degrees, which is very acceptable for me. After that, I began, you know, the penile rehab with the Restorex device and also with a penile pump to help restore length and girth. But more than that, it was time for me to start really taking into consideration all other aspects of my health. One of the first things I know that you asked me when I was down there, aside from being diabetic, was if I had sleep apnea. And I was like, how did she know that? Of course I did. And I explained to you that I had quite the love-hate relationship with that machine. I still do, but I still use it. And you got me a referral to a neurologist down there who helped straighten me out with that. You also got me a referral to a sex therapist, because I had come to you and I said, hey, Doc, you know, I know that I'm pushing a lot of this stuff to the back of my head because I just did not want to deal with it. Oh, I got the perfect person for you to see. And it helped me understand that the things going on with my penis, with my body and that, some of it was probably caused by unhealthy lifestyle choices that I had, but also that things just happen. And my penis is just a piece of tissue and it can be fixed. And it gave me a lot of hope. When I saw you and we discussed all the different treatment options, you know, I think I remember telling you, or if it was Dr. Sandberg, that there was no way nobody was going to take a knife down there. Nope. But now I think if the option was the only other option, that I could still live a fulfilling sexual life, that I know I would consider it, and I would probably allow that to happen. But like I said, you and I have been through a lot together, and for that, I'm very grateful. And I'll let you go on with your presentation now, and we can go through some of this information for the guys out there.
Awesome. Dennis, thank you so much for sharing. And, you know, for you, Peyronie's is what opened the door to healthcare and to getting so many aspects of your health, you know, straightened out, shall we say, pun intended, I guess, with that one. But, you know, your message is that, you know, sometimes it takes a whole village to help someone. And when people are coming in with a chief complaint or a chief diagnosis of one thing, that's not the only thing going on in their lives. And I think a lot of what we do at the University of Iowa and what makes kind of what gives us our special sauce is that we care about all these other aspects, because everything is related. The sleep apnea, the low T, the Peyronie's, the ED, the, you know, obesity, all of those things, when optimized, actually optimize every other way that we treat those other problems. So thank you again for sharing. My role during tonight's webinar is to keep us on time. I don't always do an awesome job at that, but I'm going to try to end us at 7 p.m. so that we're talking here for that 1 hour. You will get a link to this recording at the end. So Dennis and I, we're just talking tonight. Sometimes we talk a little quickly. We provide a lot of information. I don't want you to feel like you have to digest everything that we're talking about over the next 50 minutes. Tonight, we're going to introduce some of these main concepts, and then you can refer back to this PowerPoint and presentation, however many times you need to really digest some more of the information. At the end, we'll go through Q&A. So I'll keep an eye on the chat box throughout the session. And then there are some great questions that people submitted previously. And so a lot of those questions I'm actually going to address during this PowerPoint presentation. And then we have a few at the end that I'll address. And then if there are ones that come up during the webinar, then please feel free to put them in the chat box as well. I have a couple of disclosures. I'm a consultant for, and I receive grant funding from Boston Scientific and Endo Pharmaceuticals. And these two companies give me a lot of tools in my toolbox. And that's why I can have conversations with people like Dennis and others to tell most men that there are very few men in whom I can't restore structure and function. And that has very little to do with me, but a lot to do with the hundreds and thousands of hours and millions and perhaps billions of dollars that have gone into research and development to help you. And so for these tools, we can help a lot of people. It's why I love to do what I do on a daily basis. I can help people, and I feel grateful for that. The learning objectives for tonight, we're going to start with the basics, the basic penile anatomy. Like Dennis alluded to, when you break down the penis into the parts, the simple parts of anatomy, it's really hard to offend someone when you talk about anatomy and understand what's going on there. And in order to understand abnormal structure and function, you first have to understand normal structure and function. And so that's what we will begin tonight. And then we'll talk about the basics of Peyronie's disease, or PD, the evaluation when someone comes in to see a healthcare provider about it, and then we'll tackle some management options. So let's start with basic anatomy. And I'm going to, one second here. Okay. So the penis is comprised of 3 tubes. And you have 2 erectile bodies that sit here, and they're actually connected in the middle by a thin septum. So if we inject, let's say, medication into one side of the penis, that medication will also go to the other side. And then you have the urethra, and you can sort of see the outline of the urethra, which you can oftentimes see in a real person as well, especially if that person is erect. That structure down here, that's the tube that someone urinates out of. This is the glands of the penis. This is what we call the penoscrotal junction. And then we have the scrotum here, or the testicles that sit inside. Now, the penis is literally a sponge. This is what each erectile tissue is made up of. And so when a man gets an erection, you have blood flow that comes into this spongy tissue. It fills those spongy spaces and enlarges them. And then you have veins, and there are tiny veins that sit in between this spongy tissue and what we call the tunica albuginea, which is really key when we're talking about something like Peyronie's. And this like blue tissue here is this fibrous tissue, connective tissue that surrounds the spongy erectile tissue of the penis. All right. And then on this model here, so again, we have the penile shaft, and then we're going to look on how it looks on the inside. So let's look at it. If I put someone in half like this is what we're looking at. So we have the pubic bone right here. We have a testicle, we have the urethra. So that's the tube that you urinate out of. And then sitting right on top, this is where we have those erectile bodies. The other key thing when it comes to those erectile bodies is that they don't go all the way out to the tip of the penis. They actually end here in the mid glands. And that's important for when we talk about something like penile implant surgery. The other thing to keep in mind, especially when it comes to Peyronie's, or for people who, let's say, have erectile dysfunction and don't get erections for a long period of time, is the penis shrinks. It gets shorter, it gets thinner. And for people who, let's say, put on some additional weight, oftentimes there's a buildup or excess weight or fat that sits right on top of this pubic bone. And so when there's excess tissue here, it is literally burying the shaft and can cover the shaft and bury it by inches. So oftentimes when I see men in the office is I gently push back this tissue and I put the penis on stretch and I show him, you're normal. You have a normal sized penis. It's just this extra tissue right here is literally burying several inches of a lot of, male penises. The other thing too is the erectile bodies here, they're connected to the pubic bone. So that's a fixed structure. And so the whatever excess fat is on top of there can certainly cause penile shortening. Dennis, do you want to add anything there when it comes to the importance of weight loss, and penile length?
Oh, definitely. As part of this new healthy Dennis over the past, just about a year now, I've lost close to 50 pounds, about 48 pounds now. I've put on a little bit over the last couple of months, but in general, it has helped all around in my health, my breathing, my ability to go up and down stairs. But most importantly, it has added length back to my penis. Maybe an inch, maybe an inch and a half. It's amazing what it does for you just to get that extra weight off of you, and it helps.
Awesome. Thank you for adding that additional information. Okay. So when it comes to Peyronie's disease, it's an acquired penile abnormality, which is different from someone who, let's say, is an adolescent and starts having erections when they're a teenager and notices penile curvature. Or let's say a baby and the parents come in and bring the child in or the baby in and say that the penis curves down, for example. That's a different process and not something we're going to get too deep in tonight. That would be congenital penile curvature. And oftentimes congenital penile curvature points down towards the feet. Most of the time when we see guys come in with penile curvature, that scar is on top of the penis, we call the dorsum of the penis up here. And so the curvature actually goes up towards one's face. So when we talk about PD or Peyronie's, we're talking about a curvature or deformity in the penis that develops at some point later in life, but was not always present. It is the fibrosis of that tunica albuginea, that connective tissue that surrounds the spongy erectile tissue. Fibrosis is scar, and scar doesn't stretch. And whenever we injure any other part of our body, it's common. It's the body's natural, normal response to form scar, but oftentimes we don't notice it, or it doesn't change how our body and body parts function. But when scar tissue develops in the penis, it can be a very obvious thing that a man will note when he has an erection. So just going back to scar doesn't stretch as well as normal healthy tissue. And because of that, it causes a curve in the direction of that scar tissue. Now, Peyronie's can be accompanied by pain, deformity, erectile dysfunction, and certainly a lot of distress. And part of that distress is because a lot of men never knew that this could happen. We talk about safe sex practices, especially in young men, adolescents, and what we really are referring to is using a condom or protection during any type of sexual activity. But what we also need to tell men is you have to be careful with your penis. We need to tell partners that as well, is you have to be careful with your partner's penis, because you can injure that structure, especially if that penis is not fully erect during sexual activity. And because a lot of men don't know that this could happen, don't know where they can go to get help, and because a lot of healthcare providers don't know that there are treatment options, even a lot of urologists are not necessarily taught how to treat Peyronie's. It's certainly within our guidelines, and it's something that all urologists, I think, should be trained to deal with, or at least refer if they don't treat it. But the reality is a lot of people don't have this conversation with patients. We as healthcare providers assume that if something is important to a patient sitting across from us in the office, they will bring it up during a visit. So most of the time, most healthcare providers aren't, as they go through, oh, any fevers, any chills, any shortness of breath, any penile curvature, that's not part of their questioning. And oftentimes as patients think if something is important, then the healthcare provider will bring it up. And so what happens is nobody brings it up in that conversation, and the provider might be, doesn't want to, let's say, embarrass the patient. The patient doesn't want to embarrass themselves. And so these conversations, even though this process is common, we don't really have a great understanding of how common it actually is. There are two different stages of Peyronie's disease, and it's important to try to tease these out because it will affect what we're going to do with that problem at any given time. When we talk about the acute stage of Peyronie's, we're talking about this inflammatory phase. And inflammation, whenever it happens anywhere around the body, inflammation can cause pain. It's why we take anti-inflammatories for pain to decrease inflammation. The active phase is also when the penis is changing. So it could be that you wake up one day and you notice a curve, a lump, some indentation or hourglass of the penis. And then over the next few weeks, you notice that maybe it's getting better, maybe it's getting worse, but it's just not consistent. So that is part of that active phase where that tissue is still remodeling. Now, in our guidelines, and a lot of people will say, okay, so if you're coming in to see someone like me, a urologist, then, we'll give you some medications to treat the pain, anti-inflammatories. And then why don't you come back when everything has stabilized, you look down and you note that it looks the same for the past like 3 to 6 months. And then we'll treat it, and then we'll do something about it. But a lot of us now who commonly see men coming in with Peyronie's, we have a different thought, right? And so our thought is, if someone's coming in and things are changing and things are still active, well, maybe that's an opportunity. That's an opportunity, a door that's open to say, let's do whatever we can now in terms of rehabbing the penis to see if we can change the course of this disease. And I am a huge proponent of early intervention and penile rehab while these things are changing to see if we can make it less severe. When it comes to the stable phase, the chronic, the fibrotic phase, this is typically when the pain has resolved. Sometimes this is a little bit difficult to tease out because someone can have pain with an erection because maybe there's some pull or tension, or when they try to have penetrative intercourse, it can cause pain for them or their partners. But usually what we're talking about with the active phase is like if you touch the scar, it's painful. Or even just sitting down, let's say when your penis is flaccid, you have pain in the penis. And so that's how I usually tease those out. It's different if you have pain with a full erection when you're penetrating versus when you just touch the area, it's very tender and sore. The stable phase is also characterized by the condition not changing for at least 3 months. Some people will say 3 months, some people will say 6 months. Usually if someone comes in, they say, for the past 2 or 3 months, I haven't noticed any changes. I'll consider that person within that stable phase. And usually this stable phase will come about within 12 to 18 months after someone notices a change in their penis. Now, I don't see a lot of men in my office when changes are starting to occur. Oftentimes I see guys who have been going through or noticing these changes for 6 months, 12 months, 18 months, 5 years. But if you are starting to notice these changes, I would get in to see someone and start getting these rehab products so you can start early, because that is a time where we could potentially change the course of the disease. I do tell patients that, and the research suggests that things will stabilize. So they won't change forever. There is an end in sight. It just differs for everyone, and everyone heals and scars a little bit differently. When we talk about how common it is, we don't know is the short answer. When it comes to what's been published in the literature, there's a wide range, 0.5% to about 20% in different populations. but it's likely underestimated because, again, if we're not asking the question and our patients don't know it's a problem, or they're not getting erections, or they're not sexually active, or they don't know how to bring it up, we're not going to really know how common this process is. Now, the reason why I say it's also probably more common than we think is because recently, with direct-to-consumer marketing by companies like Endo Pharmaceuticals, who have the product Xiaflex, I don't know if you've seen like the carrot commercials, the eggplant commercials, the veggie commercials on sports channels, et cetera. And so they're saying if you have a lump, bump, or curve, you should schedule an appointment to see a urologist. So that direct-to-consumer marketing has actually been a wonderful thing to happen because it's opened up that door for a lot of men that didn't know what was going on, but then they see those advertisements and they say, oh, that's what's going on. I need to see someone for that. And those commercials start to normalize the conversation and put a name to a problem. So since those ads started coming out, I've started seeing a lot more patients in my office with this, which makes me think it's way more common than even perhaps this 20%. Now, when it comes to causes, we don't always know the cause. There are some men who come in to say, I was having penetrative intercourse with my partner. I hit their pubic bone. I immediately heard a pop or felt a pop. I lost my erection. I noticed some swelling. Like in that case, that guy may have literally fractured his penis. You can do that. Now, the penis doesn't have any bones in it, but that connective tissue that surrounds that spongy tissue, that can actually tear. And that's what we mean, what we mean by someone fracturing their penis. And when something tears, that can lead to scar tissue down the road. So there are some situations I've had someone say, a dog bit that area, or, I had some procedure, even if it's unrelated to the genitourinary system, they had some procedure, they had a catheter in, they woke up and they just noticed scar tissue, or they had their first erection after that procedure, they noticed some curvature. So we certainly hear those stories, but in general, a lot of people don't have an inciting event. They might just look down one day and notice that something is different or changed. And so what we think is that it's these microvascular traumatic events. And if you think about the penis in a boxing ring, I mean, that's really what it is over a lifetime. And when you look at a boxer, someone who's been doing that for a long period of time, they wear it on their face. Like you can tell, that they've taken some punches. And that's really what the penis has been through as well. And so it's common for there to be traumatic events to the penis. And just some people in response to those traumatic events will form scar tissue. So we think in general, it's from repetitive minor trauma to the penis, which causes changes in collagen, that connective tissue, which causes inelasticity and scarring to occur. In terms of the natural history, some guys come in and will ask, well, will it get better on its own? And in the minority of people, some will improve. We also don't have a great understanding of this either, because the men who notice something that then get better, they're never going to make it into an office like mine. So I don't know in truth how many men notice something and then where it gets better, where they don't have any problems. Most will stabilize, and some will worsen over time. In terms of the pain, most of this pain in the penis will improve or completely resolve without actually requiring any intervention. We are going to delve into the evaluation now, and we're going to go through the common questions that someone like me would ask if you come in to see us in the office. And the reason why I'm going to list all these different types of questions is so you can be prepared if you're coming into the office to think about what these responses might be ahead of time, so you can kind of pay attention to these things before the visit so you can report accurately. Questions we'll ask: when did you first notice your penile curvature? And not everyone knows. Not everyone is paying attention to the area, right? Or if you're not getting regular erections, you may not know. But I'm looking for, was it 2 weeks ago, 3 months ago, 6 months ago, 10 years ago? Was there trauma? What were your initial symptoms? Did you feel a pop? Was there bruising? Questions like that. And then we'll ask you to describe the penile curvature with an erection. So how much is it curved? And people, I'll kind of show my arms and say, this is 0 degrees and this is 90 degrees and this is 45 degrees. Where would you anticipate your curvature to be? I mean, the best way to do it is to bring in pictures into the office on your phone or print it out or send electronically through electronic medical record so that we can actually objectively measure the curvature. And rather than guessing and sort of describing in vague terms, I have some people send me PowerPoint presentations. Those typically tend to be the engineers, or we'll draw something on a piece of paper. And then we'll ask you in which direction, left, right, up, down, or a combination. Is there a presence of an indentation, hinging, or buckling? So when we talk about the indentation, it could be on one side, it could be on both sides. It's sometimes what people will describe as like an hourglass deformity. And have you noted penile shortening? Most people coming in with this concern have noted penile shortening because the scar tissue is shortening the penis and doesn't allow the penis to expand like it used to. So the common thing is for people to come in and report that their penis is shorter, and even with that scar tissue and perhaps no longer regular erections, that their penis is also less girthy. So photos of the erect penis is very helpful, especially for that initial visit. If let's say you're unable to get an erection at home, either without any erectase, or let's say you don't have anything like Viagra or Cialis at home to even see what the curvature is to take photos, then you can, when you come into the office, we can either inject the penis with the medication to induce an erection to visualize the curvature as well, and that can be helpful. And then we'll ask, is your penile curvature stable? And if so, for how long? And if not, in what ways is it changing? Better, worse? Is it developing a leftward curvature, a downward curvature, hourglass? And then pain. So do you have pain in the flaccid state just when you're erect? Is it with intercourse? And, if there's discomfort or stretching with attempted intercourse only, then as I mentioned before, I'm thinking that perhaps this is more so the stable phase, especially if you're not noticing any additional changes or worsening of the curvature. And then we go to erectile function, which is, I'll show the algorithm in a few slides from now. It's sort of one of the break points of this algorithm, whether, how we decide how to manage this going forward. So a big question is, do you have satisfactory erectile function? So that if we fix the curvature, would you be satisfied with your erections? If you're not satisfied with your erections and we fix the curvature, we're not really helping you out that much. And so those two components are very important to understand. As Dennis mentioned, his erectile dysfunction preceded his Peyronie's by 10 years. That is really common. When it comes to factors that predispose people to Peyronie's, diabetes is one, and also erectile dysfunction. And for the ED one, it kind of makes sense because if the penis is not fully rigid, it can be more prone to a flexion injury during sexual activity. So whether ED preceded something like Peyronie's or the Peyronie started first, it's also common to have erectile dysfunction after someone notices Peyronie's disease. And that goes back to the structure and function of the penis. Is Peyronie, sometimes the scar tissue can involve the spongy erectile tissue, but also where these veins are supposed to close off to keep blood in. When there's scar here, those veins may no longer be able to close off. And so that can cause issues with maintaining an erection. Other questions we'll ask, do you take any medications for erectile dysfunction? Because if you're taking something like Viagra, Cialis, and getting great erections, well, that's great. We can continue on those medications and then work towards treating the curvature, fixing the curvature. And then we also want to know about some things that may seem a little bit unrelated, but may affect our management as well. So any issues ejaculating and any decrease in penile sensation. Changes in penile sensation and ejaculation can be noted with a lot of different medications, especially those that are used for mental health, like anxiety and depression. And penile sensation can be affected by those medications, as well as from diabetes. And so these may affect whether or not you might be a candidate for one of our surgical options. But also, if we fix the curvature and we fix the erections, we're not going to be fixing the ejaculation component. All of these things are actually very separate processes in the body. We'll also ask if you've been previously evaluated or treated for your penile curvature, and if so, what treatments have you tried and were they successful? And then lastly, but certainly not least, is how bothersome this condition is for you. Some guys will come in to say they've noticed this change, but it actually doesn't cause any issues with penetrative intercourse. They're not bothered by it, and their partner doesn't have pain. And in those scenarios, I would still recommend that you rehab the penis in order to maintain or prevent any loss of length or girth, and to certainly keep that tissue healthy, but we don't necessarily need to fix anything. And so, there are plenty of people who come in that say, I'm dating and it's embarrassing. And even though I don't currently have a partner, I want it fixed before I get back into the dating field. And that's reason enough. You don't have to have a partner to be a candidate for a treatment option. Dennis, here's where I want to go back to you to give us a little bit of information about how this affected your relationship with your partner.
Oh boy. Since it started back in, 2017, 2018, I'm going to be honest, it was approximately 3 years before my wife and I could have penetrative sex. It was very disconcerting, to say the least. I mean, it bothered me quite a bit. After treatment and after losing the weight and everything, it's now back to normal. That penetrative sex, the intercourse, is back where it should be. And I'm very happy and very pleased with it.
Yeah. And Dennis, thank you again for sharing. Sometimes this is like the first thing that starts off that then changes the intimacy and the relationship in a couple. And then people don't know how to talk about it. And then let's say, and then you might be sleeping in different rooms, and then the conversation changes. It's really hard to get back there to say, look, our sexual health, our sexual life together was really awesome. What would it take to get back there? And I love when patients come in with their partners. I think it says a lot about the relationship. By no means do you have to come in with a partner, but it's nice for me to be able to talk to both people in a partner relationship at the same time, so that I can also tell the partner, it's not you. We got to go back to anatomy. So when I'm telling the man about his anatomy, I'm also telling his partner so that they also understand it's just based on anatomy, their scar tissue. It's not them. It's not their body. And so that's helpful for me to do as a healthcare provider, so that some of my patients maybe don't feel comfortable or don't know how to have those conversations with their partner. All right. And then when I evaluate someone in the office in terms of the physical examination, I will ask you to stand up and bring your bottoms down. Or if you have mobility issues, I'll have you lay on the exam table. And I'm just, first of all, I'm taking a look, I'm taking a lay of the land. I'm just looking at the skin health, looking at the tissue overall. Are you circumcised, uncircumcised? Does it look like there's excess tissue, mons tissue that's covering the penis? Where's the urethral opening? That's that tube that you urinate out of. Because sometimes curvature that goes down towards your feet, that can actually be associated with the opening of the urethra, not with that being in a different location, kind of lower on the tip of the penis. And so sometimes those things will come hand in hand. I'm assessing penile length, and I'm palpating the penis. So I'll pinch the penis, and I'll tell you as I'm doing this, because otherwise for some people, they're like, what are you doing? I'm pinching the top part of the penis here, because that's where that scar tissue typically develops, that dorsum of the penis. And so I'm feeling if I can feel any scar. Now, a lot of guys will get sent to me because someone else has examined them, or the person has examined them, and they don't feel any discrete scar in the penis. So when I see those guys, oftentimes it's because the entire top part of the penis has actually scarred. It's not just one small area of like 1 centimeter. It's actually the entire top part that feels like scar. And I've done enough of these exams to know kind of when I'm feeling that. But that's why, some guys will get sent to me because someone else did not feel a scar. And then penile assessment while erect. So it's always nice, again, when you bring in that photo, if you're unable to get erections at home or with medications, then we can give you an injection in the office to induce an erection. I try not to do this if I don't need to. It's always nice to be at home to take a picture. But if I do need to, it's certainly an option in the office. When it comes to imaging, This is not something I routinely do. It's not the wrong thing. Depending on the provider you see, that provider, if you're coming in with erectile dysfunction and or Peyronie's, might get a penile Doppler on every person coming in to assess blood flow, to assess the scar tissue. I find that my exam alone is helpful enough. And also, you know, your history, your story tells me whether or not your erectile function is adequate. If you don't get great erections and then you take Cialis and get great erections, there's nothing that that Doppler ultrasound is going to tell me that that Cialis working for you doesn't already tell me. With the Doppler, in order to get the good information when it comes to blood flow, you also need to do a penile injection in the office. And that's another reason why, if I don't need to do something like this, I don't. Now, where some people will do the Doppler more often is to assess that scar tissue. And that can affect management in some folks, because if you see calcium within the scar, you're less likely to respond as well to something like Xiaflex if there are calcium deposits in the scar tissue. And that's where some healthcare providers will use that Doppler. All right. So in the last, 15 minutes, 20 minutes or so, we're going to get into the treatment options. I'm going to give you the highlights on each of these slides. There is a good amount of text on each of these. I'm not going to read through everything. That's something that you can delve into at a later date when you're going through the recording. When it comes to that treatment phase, we are talking penile rehabilitation. So we got to treat the pain, and anti-inflammatories like a daily Aleve can be helpful for that. Our national guidelines, there was a question talking about shockwave therapy. Where does that play a role? So there's no good evidence to say that shockwave therapy is beneficial to treat curvature. But there have been studies, and some people will offer shockwave therapy to help with the pain in the penis, but not with the curvature itself. But it can be expensive. It's not covered by insurance. And so anti-inflammatories are typically what we will do for the pain. I also, unless there's a reason why I can't put someone on a daily Cialis, because let's say they take a nitroglycerin for chest pain, I will put most of my patients on 5 milligrams daily Cialis to encourage as much blood flow to that penile tissue as possible. And there also may be some anti-fibrotic or scarring effects. A vacuum pump, incredibly important for regular expansion. If we take this sponge and put it under the faucet and wring it out and say, I'll see you back in a year, this sponge will atrophy. It gets smaller. And when I put it back under the faucet a year later, it will not expand like it did a year before. So if you are not getting daily erections, you must stretch out that tissue in some way, shape, or form. If you're taking daily Cialis and that's good enough to wake up with erections or get erections at nighttime, then that's doing rehab from the inside out. And that's awesome. But if you're not getting those daily erections, then getting a vacuum pump or using it in association with Cialis is critical to maintaining penile health, even if you're not using it for sexual activity, simply to maintain the health of the penile tissue. Traction is incredibly important to minimize shortening or worsening of curvature. And then I will consider pentoxifylline for anti-fibrotic purposes for those who, let's say, are not a candidate or can't take Cialis, but I would say that is the rare occasion that I ever find use for that medication. In terms of other medications or pills, there are no oral pill medications that have been shown to be beneficial when it comes to the treatment of Peyronie's disease. I listed the ones on here. You name it, people have tried it, but we just don't have great evidence to say that these have worked. I've seen plenty of guys who have been started on these medications and they come see me and they say, I've been on this medication for 6 months, it's not working, and we just don't have good evidence to say that they're helpful. So let's talk about where you can get a vacuum pump. I used to tell patients, oh, get whatever you want. Go to Amazon, go online, go to a sex shop, you get whatever vacuum pump. But it's like sending someone to Walmart and saying, go ahead, get a protein blender to make a protein shake in the morning. And you walk down the blender aisle and you realize there are 20 or 30 different options. No one's really helping you decide which one is most appropriate for your goals in the morning when you're making your drink. And so you walk out and you don't get anything. So folks, this is a place to start. These are products that either I have seen myself or that patients have gotten and said, Dr. Perlman, I got this product on Amazon. It was $56. It works well. Tell your friends. So folks, friends, I am telling you, there are certainly other products out there. And if you want to look at other products, by all means, but some people just need a place to start to see what are some of the features of some of those good products. And then they get one of these. So the key thing is just find one that's within your price range, because insurance doesn't cover it. So you're going to go directly to these sites and purchase one. Insurance doesn't cover it. So just make sure that you get one that's not going to bankrupt you. Now, you also, you're going to get what you pay for. So if you get a $25 one, it's not going to be a very good product. So the good ones are going to be kind of in this mid-price range. If you're looking for the best product, this Gesiva Medical one is a great quality product. It's battery powered. The other thing to keep in mind with these products is how good is their customer service, because you want to be able to call someone to talk through some of these products so you can optimize how it works for you. And if they don't pick up the phone, they have poor customer service, they don't have, a money back guarantee, it breaks, what happens, no warranty. Those are things that you need to consider when you're looking at these products. New Care Pharmacy in Coralville. Robbie, he's a lead pharmacist over there. He has a particular interest in building a men's health portfolio. He's been great in terms of stocking this products. He actually got a whole shipment of sex tools this week, vibrator products, you name it, he's got it. And so it's nice for us as healthcare providers. Sometimes it makes it a safer place if we medicalize something. So rather than telling, my 70-year-old patient, hey, why don't you go to Romantics down the street? I can say, hey, why don't you stop by New Cara on your way home? See what products he has, vacuum pumps and other, sex toys. And it just can be a more comfortable space for folks. In terms of the regimen, there's no right way to do it, but we do have a proposed regimen here. This was created by one of our pelvic physical therapists with a particular interest in penile rehab. Her name is Mary. And this is one of the vacuum pumps here. And so what you can do is you can put this on the base of the penis. You push this button here. It sucks blood into the penis. You hold for a couple seconds, relax, let the blood come in, do it again, on, off until you get all this blood in the penis. And so you can try different ways. You can maintain suction for, let's say, 10 minutes. You can maintain suction for 2 minutes and then come off with the suction. Whatever hurts you, don't do. Whatever feels fine or like a stretch, that's all fair game. Dennis, tips from you.
Tips from Dennis. Gentlemen, I think the first biggest tip is, guys, if you have a forest growing down there, trim it back. You get much better contact to the skin than having to go through the bush, so to speak. Secondly, and most importantly, is put a little lubrication around your penis, because it tends to, there's moisture there as it is, and it will stick trying to insert it into the penis. Then when you go to try to vacuumize, you're going to end up with another bend in your penis that you don't want to have happen. Just put a little lube around it, slide it in, make sure you're good and comfortable before using the vacuum on it.
Great advice, Dennis. And actually, the advice that I learned from Dennis during one of our previous webinars has allowed me to better counsel patients when it comes to these devices. In urology training, we don't get taught about vacuum pumps. And so much of what I know about talking about vacuum pumps and all the rehab protocols are things that I learned from my patients. I have a lot of guys that say, does it really work? Like, does it really work? And my response is, I wouldn't recommend that you spend money on these products if they didn't work, because that makes me look silly and that wastes your time. And so the reason why I feel so strongly about penile rehabilitation protocols is because I've had people just like Dennis come in and say, it works. I've noticed. I may not be back to what I was when I was 19, but I'm getting better. I have hope. I feel optimistic. I see progress. So many men need to see that. And even though it's not all about the penis, sometimes that's where it begins and you need to see progress. And that's where things like rehab is just incredibly important. Dennis, anything you want to add there?
Yeah, like you said, my length and my girth is returning to normal in that. And it wouldn't have if you hadn't even brought up, rehabbing it after the treatment options and that. And that, along with, I think the next thing you're going to talk about is the traction device, but we'll go to that now too.
Yes, thank you for teeing me up here. This is a Restorex device. It's a traction device. There are, like the vacuum pumps, there are a lot of different traction devices out there on the market. I just haven't heard good things about other devices. And so that's why I do recommend this device. I don't get any kickback from the company, but it is a good product. You know, everyone who gets it says this is a well-made product. And folks, it really is. This product you can get from New Cara Pharmacy, from Robbie. He usually has those in stock. You can also get them directly from the website. Insurance typically doesn't cover it. It's an investment. It's about $500, but folks, I'm telling you, it is worth it. It is a good quality product. What you would do is you would clamp the glands or that tip of the penis in this tip of the device right here. It's a spring-loaded device. So oftentimes as the protocol, you'll put the penis straight out and hold it there for, let's say, 15 minutes, and then you can bend the penis in the opposite direction. Now, of course, you can hold your penis like that for that amount of time. And by the way, this is in the flaccid state, so not when the penis is rigid. But this device is something you can put it on, watch TV, and not have to hold your penis there for a long period of time. It's going to feel like you're pulling your penis off your body. That's normal. That's expected. Another piece of advice to make this more comfortable, it does come with this in the packaging, but I've had a lot of patients say this is not great in terms of protecting this tip of the penis here. So I actually reached out to Dr. Trost, who was the one who really came up with this product a few years back. And I said, you know, I have some guys and they have terrible pain at the glands, but they really like the product. What do you have to recommend? And he recommended these makeup pads, which you can actually order from Amazon. And it allows you, if you use the makeup pads that have this little strap here, you can put the strap on either side here with the soft part in the center here, and it can make it a lot more comfortable when you clamp down on this device. Dennis, what tips do you have when it comes to traction?
Well, I think one of the things that I noticed when I was using it, I would use the clamp just behind the glands itself, so that it had that little extra holding power, I guess you might call it. Other than that, if we can go back one slide to the picture of it, the actual clamp head on there, as you can see, with the blue circular cylinder just behind that, that clamp does come off, and you can utilize that to clamp your penis and then push it back in, and it'll catch again, so that then you can bend the top part of it to whatever angle you feel comfortable with. There's also the bottom part of it, the ring there where the base of your penis is at. You can rotate that whole device around based on whatever the curve of your penis is. So if your curve goes out, 40, 50, 60 degrees to left or right, you can adjust this to get that to fit the curve of your penis in that. And learning about the makeup powder pads, I wish I would have had those back.
I know. Then. I'm sorry, Dennis. I didn't know
no,
back then.
Hey, we're both learning still.
Now, the other thing when it comes to a vacuum pump and the Restorex device is you don't even need to have curvature in order to benefit from these devices. More and more research is coming out that uses these devices for anyone who is just not getting regular erections, or let's say if you have your prostate removed for prostate cancer, oftentimes penile shortening is something that happens after that. And so these, you can use it to just stretch the penis out straight, and that can help in terms of restoring penile length. Now let's get into treatment options. So this is in the stable phase. So let's say you come in, you started noticing changes 2 months out, you had some pain, you're rehabbing the penis. Some people will ask, is it okay if I get erections? Yes. The best thing you can do for yourself is encourage regular erections. It might feel sore, but you are not hurting anything. You may not be having penetrative intercourse or sexual activity because it might be too difficult or painful, but getting erections is good for you. But let's say things have stabilized. So it's been 3 months, it's been 6 months, the pain has gone away, but it's causing issues with penetrative intercourse. It hurts you, it hurts your partners. These are the three different ways that we can treat it: injections, surgical curvature repair, and then surgical curvature repair plus a penile implant. We'll focus on XIAFLEX injections when it comes to injecting the plaque inside the penis. There are two other options, interferon and verapamil, but XIAFLEX is the only FDA-approved medication to treat Peyronie's disease, and that's the one that I offer. The other thing too is some people might offer some of those other medications because XIAFLEX, if it's not covered by insurance, can actually be a very expensive therapy. We're lucky in the state of Iowa that a lot of the insurance companies that cover our patients who see us, and we can do this for Medicaid patients too, like no problem. We're very lucky that it's cost effective for a lot of folks, but that might be why some other people don't offer XIAFLEX, is because it just might not be cost effective and it could be cost prohibitive for their patient population. So XIAFLEX, I always show the needle in the office, and it's not to scare you. I promise you, it's not to scare you. It's just you have to know what you're getting yourself into with this procedure. Nobody, not even Dennis, high fives me after a XIAFLEX injection, but people get through it. My job when I'm counseling someone in the office is to try to figure out what type of patient are they? What will they do well with? I don't want people to suffer, whether it's through surgery or injections. I have zero interest in that. And so the reason why we have these long conversations and we ask a lot of questions is I'm trying to tease out, how can I get you the goals that you're looking for without putting you through unnecessary trauma? XIAFLEX, it's so important that you do this with penile stretching. So just the injections alone is not going to fix the curvature. I put right here, this is the volume that we inject. It's a very small volume. It's 25.25 cc's. It's a quarter of a cc, a quarter of a mil. It's a small volume. It doesn't dissolve the entire plaque. What it does is it softens the scar where that scar tissue is causing maximal curvature. Candidates for this procedure are going to be those with curvature between 30 and 90 degrees, with intact erectile function, with or without medications or a vacuum pump. We have to be able to feel that plaque so we know where to inject this medication. And then you can continue throughout these 4 cycles. The process is 6 months. It's a time commitment. You can continue as long as the curvature remains greater than 15 degrees. I tell all my patients, expect bruising and swelling. That is common with these injections. So that's I wouldn't even say it's a real side effect. Like, that is common from this therapy. And penile fracture is very rare. Obviously, people get scared of that, but that's why we have some limitations related to this therapy. So no sexual activity between the first and second injection, and then 4 weeks after the second injection. And you must limit your activity the day of each injection until bruising and swelling resolve, which could be a day for some people. It could be 7 days for other people. As I alluded to, it's a 6-month process. We typically schedule all these appointments up front. Before we schedule anything, we actually have you fill out a benefits investigation to better understand, so that you understand what the cost is going to be to you. We don't like any surprises going into this. For some people, it's nothing. For some people, it might be a few $1,000s. And so that process of 6 months, I'll go through a cycle. The first injection of each cycle, you actually get 3 injections. One is to give you an erection so we can mark out where that maximal curvature is. Then we give a second injection to get the penis to go down, and then we inject the XIAFLEX. 1 to 3 days later, or at least within a week, we have you come back and we just inject the XIAFLEX because we know where we just injected. And then 1 to 3 days later, you come in and we model the penis. It's kind of a fancy term. You're not modeling, but if the scar tissue is right here, we put our fingers on either side of the scar and we stretch the penis like that. And then after that visit at home, that's where you start the at-home stretches. So let's say every time you go to the bathroom, you put the penis on stretch like this to try to stretch out that scar. If you get an erection, a spontaneous erection, that's fine. You just can't use it for those 4 weeks. You can gently bend the penis in the opposite direction. It's also where I recommend using the Restorex device. So even if it's not per protocol with XIAFLEX to use something like the Restorex device, it's per protocol, it's just to put the penis on stretch. But you can imagine you're going to get way more stretch of the tissue if you use a Restorex device in combination with the XIAFLEX. Now, for surgical options, if you're like, I just want you to fix the curvature, I don't have 6 months of my life, I live 3 hours away from you, I can't make the trip on potentially 12 office visits, what do you have when it comes to just fixing it? Well, this is where the tunicle plication can be very helpful. I'll tell you, my plication patients are some of my happiest patients. And that's because they came in, we decided we were going to do this procedure. We do it. It takes about 45 minutes. You go home the same day. I'm just putting suture on the opposite side of the curvature. If the curvature goes up like this, I'm making an incision on the bottom part of the penis. I'm putting non-absorbable sutures in on the bottom part to like squinch or cording the tissue together. And so if this is the shorter side, this is the longer side, I'm shortening the longer side to straighten the penis. And then I do another, artificial erection at the end of the case, make sure everything looks good before we finish up with the case. So I know in real time that we're happy with the outcome. With XIAFLEX, there are no guarantees. Some people have a great amount of success. With Dennis, he had about 20 degrees of improvement, but that was enough for him. He didn't need a straight penis. And that's why XIAFLEX was a great option for someone like Dennis. The plication is simple. It shouldn't affect erectile function, but it will shorten the penis. If you are coming in and you're already incredibly bothered by a shorter penis, and if you were to have this procedure and notice any shortening of your penis, and if you would not be happy, I mean, nobody's happy with that. Some people are okay with it. But if it would make you frustrated, upset, unhappy, unsatisfied, then I would not recommend this procedure. We can't, estimate how much will shorten the penis with this procedure. It depends how severe the curvature is, but also, are you a grower or are you a shower? And if you normally really grow with an erection, these sutures won't allow you to do that. And so you might notice significant shortening of your penis with this. For post-op care, no sexual activity for 6 weeks, and then you can go about your day-to-day. In terms of plaque incision with grafting, some people will say, well, can't you just remove all that scar? Well, we can't. It's not a good idea to do that because, if we remove a lot of scar, we have to replace it with something. And the tissue that we have off the shelf, different products, it just doesn't stretch like normal healthy tissue. The other thing is there are more risks with this procedure. So the plaque incision with grafting, so we'll open up the scar, it'll kind of spring open a bit and we can put a patch on, but there are some risks with this. So one, where the scar typically is on the top part of the penis. That's where the nerves and the vessels are that give blood supply to the tip of the penis and give sensation to the penis. So in order to get to the scar, we have to elevate that bundle, which can sometimes be a tedious operation. That's why it can take 3 to 4 hours. And so it takes longer, a little bit more recovery, and it can worsen erectile function. So I would not recommend this procedure for someone coming in who already has erectile dysfunction because I can make that worse. And then for people who, let's say, are not getting good erections with Viagra or Cialis or vacuum pump, and they have curvature, this is where we need to fix both. We need to fix the erections and the curvature. And so putting in an inflatable penile implant alone sometimes with that device can fix the curvature. And then if there's still more than 30 degrees of curvature once the implant is in, we can model the penis, which is with the penis fully erect with this implant in while you're asleep, we'll bend the penis in the opposite direction to stretch out some of that scar. If there's still residual curvature greater than 30 degrees at that point, then we can do some of these other adjunct procedures that we discuss, application or open up that scar tissue and put a patch on there. So, and we're going to finish up here in 5 minutes. If Dennis is sitting in my office or someone else is sitting in my office, in order for us to be on the same page, we have to be looking at the same information. And I recommend that people go to see our national guidelines. You might not understand everything that's in there, but they're actually worded pretty simply and summarized in the beginning of these documents. It'll go through the basic statements, what's recommended, what's not recommended. And so it gives you a place to start when you go to see your healthcare provider in terms of what questions you might ask. All you have to do is go on Google, search AUA guidelines Peyronie's, and it's this link right here that you can pull up. All right. And then this is what the summary statements show. So it doesn't take very long to read and it can give you an overview of the options. And then we have this algorithm. This is how we break it down. Stable disease, active disease, what's expert opinion, what might be experimental, what's conditional, what's this break point in terms of a penile implant, no penile implant. And so this, I think a lot of, healthcare providers, but also patients can understand this short algorithm. The main points to keep in mind, whether it's you, your partner, or just understanding this process in general. Is it active or stable? What's the erectile function? Do we have to fix that as well? What's the degree of bother? If it doesn't bother you, then maybe we just need to continue rehab. And if things get worse, consider an intervention at that point. What's your success with rehab? I wish at the end of the day, it's great when I book surgery. It's great when I do XIAFLEX injections. But if I can put someone on a rehab protocol with a vacuum device and a Restorex device, and they come back in and they say, "Doc, I'm no longer bothered," folks, that is a win for everybody. And I'm so happy when those guys come in and say that. It's not going to be for everyone, but I'm looking at like the 1 in 10 that no longer needs an intervention. And that's a win. And then what are your goals? What are your partner's goals? And at least starting that conversation and normalizing the conversation. I have additional videos on a website, Pearlman MDs. I have a video here that I recorded with a guy who's well-known, who was involved in some of these initial XIAFLEX studies, Dr. Will Brandt. He practices in Utah, for some additional information. I also have videos with Robbie at New Care. We go through some nuances of the Restorex device, of vacuum pumps. The key thing with those devices, because they're all a little bit different and the companies know more about those products than I do, is to go to the customer service people. If you have a question about the Restorex device, call them up, look on their site, and actually reach out to the company representatives themselves. So when it comes to the rapid fire questions, I addressed a lot of these in the presentation. You don't need a circumcision. You don't need to be circumcised in order to be a candidate for any one of these therapies. Length can be restored with penile rehab. When it comes to putting an implant in, the implant is a great device. I love penile implants. It's one of my favorite surgeries to perform, but the time to rehab the penis is before I put an implant in, because once I put an implant in, something like this, then your penis may not expand as well as it used to 10 years ago around this implant. So if someone comes in and they're worried about loss of length or girth and they want an implant to restore their sexual function, I tell them I will even postpone their penile implant surgery to give them a few months of rehab before putting an implant in. And I do feel strongly about that. In terms of statistics, diabetes has been shown to be common in those with Peyronie's disease. And then, as we mentioned, erectile dysfunction as well. Shockwave therapy, there's no data to suggest that that can help with the curvature itself. Some people may offer it for pain, but would not be a typical thing that people offer. I mean, unless you're going to a shock clinic. There are a lot of clinics out there that will say, we'll cure your Peyronie's with shockwave, but they also charge a ton of money, and there's not great data to say that. So, with these supplements, look, you name it, people have tried it. There's no great data to say that these oral supplements are helpful. When it comes to insurance coverage for all the things that we're discussing today, a lot of insurance companies cover it. So this is not cosmetic. This is a medically necessary procedure. They're all elective. I mean, even cancer operations are considered elective. And so a lot of insurance companies will cover the surgeries and in some way, shape, or form, the injection therapy. And then when it comes to being born or developing this afterwards, this presentation is focused on, you had a straighter penis and then you developed a curve or some sort of deformity in the penis. And by the way, most penises when erect are less than 6 inches. So a lot of people think penises are larger than 6 inches, but also a lot of people have some curve to their penis. So you don't need to have been born with a perfectly straight penis to have been normal. So many men have some degree of curvature in the penis that just isn't bothering them. So thank you so much for tuning in tonight. I know that was a lot of information. I'm exhausted. Dennis is exhausted. But the good news is we are going to post the link to this webinar. You can watch it as many times as you want. You are not alone. The fact that you were on this webinar tonight means you are so far ahead of so many other people, even if it's just to learn about what could happen or how to restore, length related to loss after prostate surgery. I hope you learned something tonight. And I think you probably did. I learned something from Dennis. And then this is, one of many webinars that we do. We're changing it up in 2022, and we have a different topic the first Tuesday of every month. The next one, April 5th, a very popular topic on testosterone deficiency or low testosterone. And so tune into that one. And you don't have to have low T to tune in. There's certainly something you can learn about hormones in that webinar. And that's all I have. Dennis, do you want to give us some parting words, my friend?
Parting words. Guys, I know a lot of you have probably belonged to either the Peyronie's page or even the erectile dysfunction pages. If you see me out there, you got questions or anything, just hit me up, ask me. I've got no problem sitting there and discussing any of this with you. I know that, you know, when I was dealing with it, it was kind of like dealing with the 5 stages of death. I mean, there's confusion, there's embarrassment, there's anger, and then, you know, eventually you come to an acceptance. But that acceptance is only going to come when you find somebody like Dr. Perlman, who's going to give you multiple treatment options. And yes, you're going to have some tough choices to make, some tough talks with your doctor, but it works out. You can do it.
Awesome. Thank you.
All right, well, thank you, Dr. Perlman and Dennis, for sharing some awesome information with us tonight. Just some closing notes. After we end the webinar, you'll be prompted to complete an electronic evaluation for our program this week. And then you'll also receive a follow-up email with links and resources within the next week. Thanks for joining, everyone.